Welcome back, everyone, to another Explainer. Today, we're diving right into the high-stakes, super fast-paced world of adult critical care coding. We're going to master CPT codes 99291 and 99292. If you've ever felt completely overwhelmed by the exact rules for high acuity criteria, those tricky time thresholds, or figuring out exactly what's bundled and what isn't, well, you are in the exact right place. We're going to decode the whole shebang today, step by step, so you can code with absolute confidence. Let's get right into it.
Here's our agenda for today. We're going to cover 1. Defining adult critical care, 2. Mastering time thresholds, 3. Bundled versus separate procedures, 4. Multi-specialty rules, and 5. Audit defense.
All right, Section 1, Defining Adult Critical Care. Let's start by establishing the exact rulebook for what legally and technically constitutes critical care.
What's really fascinating here is just how specific the AMA is about the patient's actual condition. You know, to bill for critical care, it's not enough for a patient to just be very sick. Critical care requires direct medical decision-making for a patient who is literally facing a high probability of imminent, life-threatening deterioration of a vital organ system. We're talking central nervous system failure, circulatory failure, shock, or severe respiratory failure. The interventions have to be highly complex to assess, manipulate, and support those failing vital systems.
And that brings us to a massive misconception in the coding community. The guidelines specifically state critical care is usually, but not always, given in a critical care area. So what does that actually mean for us? Well, it means a patient simply sitting in an ICU bed does not automatically qualify for critical care coding if they are stable, right? If the patient isn't facing that imminent deterioration we just talked about, it is not critical care no matter what room they're in. On the flip side, critical care can absolutely happen down in the ER or even on a regular floor if those clinical criteria are met. Condition drives the code, guys, not the location.
And this rule right here is our golden rule for today. Once you establish that the patient actually meets the clinical criteria for critical care, your standard medical decision-making, or MDM levels, they fly right out the window. Critical care coding is strictly time-based. The stopwatch is literally your only guide here.
Moving right along to Section 2, Mastering Time Thresholds. Let's look at the math and see how these time blocks actually build.
30. This specific number is practically burned into the minds of expert coders. 30 minutes is the absolute minimum time threshold you need to hit to report the base critical care code, 99291. And hey, this includes the time the physician spends right at the immediate bedside plus time spent on the unit reviewing test results or discussing the patient's care with other medical staff as long as it directly relates to that specific patient.
So, what happens if a physician documents intense critical care level interventions, but the total time spent only adds up to, say, 25 minutes? Well, you simply cannot bill 99291. If that total critical care time falls short of the 30-minute mark, you've got to drop down to your standard E&M codes, like the initial hospital care codes 99221 through 99223, or subsequent care codes like 99231 through 99233, depending on the MDM level.
Let's break down the actual mechanics of this. Your base code, 99291, covers the first 30 to 74 minutes of critical care time, and you can only bill it once per calendar day, per specialty. Now the add-on code, 99292, that's for each additional 30-minute block. But because of CPT midpoint rules, it actually kicks in at minute 75. So 75 to 104 minutes, that equals your base code plus 1 unit of 99292. Hit 105 to 134 minutes, and you're adding 2 units. Keep this math handy, for sure, because it takes the guesswork completely out of the equation.
All right, Section 3, Bundled versus Separate Procedures. Let's dig into what actually happens during those minutes so we avoid double billing.
The AMA considers certain procedures totally inclusive to critical care. Basically, you cannot code these separately if you are already billing 99291. This list includes interpreting cardiac output measurements, reading chest x-rays, checking pulse ox or blood gases, placing a gastric tube, temporary transcutaneous pacing, managing the ventilator, and basic vascular access. The payment for all of this stuff is already baked right into the critical care code itself.
However, physicians often perform major procedures during critical care that are separately reportable. We're talking things like endotracheal intubation, code 31500, or placing a central venous catheter, code 36556. So, the absolute crucial point here is this. You can totally bill for these, but you cannot double dip on the time. Think of time spent on these separate procedures like a bank withdrawal. You manually have to deduct that procedural time from your total critical care time bank. So, if the doctor spent 60 minutes with the patient, but 15 of those minutes were spent placing a central line, your actual critical care time is now 45 minutes. Make sense?
Moving to Section 4, Multi-Specialty Rules. Let's pivot and look at the complexities of concurrent care provided by multiple doctors.
Here's a very common real-world scenario for us. You have a patient in septic shock. The critical care intensivist is there, but a nephrologist is also called in to manage acute renal failure. And both doctors are providing critical care services on the exact same calendar day. So how do we code this without triggering a bunch of claim denials?
Well, the rules are starkly different depending on the specialty. If the providers are in the exact same specialty and the same group practice, say two intensivists handing off a shift, they act as one single physician. They have to aggregate their time together. They share one single 99291 base code for the entire day. But if the providers are from different specialties, like our intensivist and our nephrologist, they can each independently report critical care codes 99291 and 99292, as long as they each individually meet the medical necessity and the time requirements for their specific portion of the care.
And just a quick but super vital reminder while we're on the subject of tracking time, critical care time is absolutely exclusive to the physician or the qualified healthcare professional. You must completely exclude any time spent by clinical staff or nurses. If a nurse spends 40 minutes stabilizing the patient while the physician is off in another room, that 40 minutes does not count towards your 99-29-1 threshold at all.
Finally, Section 5, Audit Defense. Let's wrap things up by building your shield against audits.
Critical care is a high-value service, which means it's constantly under the microscope of payers and auditors, who frankly love nothing more than finding a simple math error. These right here are the three massive audit traps that catch coders entirely off guard. First, like we discussed, billing purely based on the patient being in the ICU, without clear documentation of a high probability of life-threatening deterioration. Second, failing to deduct the time for separately billable procedures. That's a classic double billing error. And third, vague time documentation, which brings us perfectly to our final point.
While exact start and stop ranges, like, I saw the patient from 1:05 p.m. to 1:50 p.m., aren't strictly required by every single payer out there, the local chapter guidelines clarify a really critical rule. A single specific total time must be documented. The physician can't just casually write 15 to 30 minutes spent. No way. They have to document a definitive number, something like 45 minutes of critical care time was provided exclusive of separately billable procedures. Without that specific number, you literally cannot bill critical care, and you have to revert right back to standard MDM-based EM codes.
And that brings us to the end of today's deep dive. By actively applying these exact criteria, those time thresholds, and the deduction rules, you can make sure your critical care coding is highly accurate and fully compliant. But before you head out, ask yourself, based on what we covered today, how many critical care hours has your practice been accidentally undercoding or worse, overbilling? It might just be time to pull some charts and find out. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.